Welcome everyone to today's webinar. I am Ayla Ellison with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. In about a week following the webinar, we will be sending all registrants a copy of the presentation to the email you used to register. At this time, I am pleased to introduce our presenters. Jordana Bernard has more than 20 years of progressive leadership in the telemedicine industry. Jordana currently serves as the Director of Policy and Public Affairs at Telehealth. In this role, Jordana executes strategies for key telehealth advocacy and policy initiatives. Prior to joining Telehealth, Jordana served as Chief Program Officer for the American Telemedicine Association, overseeing strategic objectives to advance the telehealth industry in education, accreditation, practice guidelines, development, and alliances with professional societies, governmental agencies, payers, and industry. Jordana received a Bachelor's of Science in Biomedical Engineering from Boston University and an MBA from Marymount University. Atul Kichambre is the Global Solutions Leader for Dell Services in Healthcare and Life Science Practice with a focus on patient engagement strategies and solutions, telemedicine, and the Internet of Things. He advises and consults as a strategic partner for customers and provides industry insights and thought leadership. Atul has more than 20 years of IT experience, including 15 years in healthcare IT. He has an MBA in International Business from Oklahoma State University and a Bachelor of Science in Computer Engineering from BJTI, India. Christian Dye is currently engaged as a Senior Managing Consultant working to build out the revenue cycle consulting and engagement practice. Christian's prior experience includes Pro Systems, MedAssets, and Optum 360 for over 15 years, leading implementations, managing projects, and leading consulting engagements. Christian lives in Carrollton, Texas, and is very excited to be working for NTT Data. At this time, I am pleased to turn the floor over to Atul to begin today's presentation.
Thank you, Ayla. Good morning or good afternoon, everyone. Welcome to this webinar. Due to continued industry investments in clinical research, we have now invented new breakthrough therapies. We have created sophisticated procedures and developed targeted and precise medications. Rapid improvements in medical technology has made it possible to diagnose very complicated disease states. It has also enabled us to operate on human bodies in ways that was not possible even a decade ago. And more importantly, improve outcomes and quality for patients. Good news is our population is living longer, but this also means that we now have aging population that is dealing with growing number of chronic conditions, which requires complex care coordination and puts pressures on capacity of our healthcare system. On the other hand, we don't have enough physicians and clinical workforce to meet this surge in demand for healthcare services. Fundamental pillars of managing chronic patient population is primary care physicians. 20% of our nation's population does not have access to primary care doctors, and it is projected to get even worse in future. As a result, our healthcare system is pondering over important questions. How do we solve this problem? How do we ensure all our population, and not just those in selected geographical areas, have access to primary care? How do we maximize bandwidth of existing clinical workforce so they are able to see more patients? Well, one way to address some of these issues is by use of telemedicine and virtual care services. Next slide, please. With advancements in technology, smartphones, and network bandwidth, we are at the cusp of experiencing significant shift in how care is delivered. By leveraging video visits coupled with smart software platforms, we are able to scale our clinical workforce better. Virtual care allows us to deliver anytime, anywhere care to patients in a convenient manner. The statistics on this slide highlights shifting expectations from patients. Since healthcare consumers are getting convenient services from other non-healthcare industries, they have started to expect the same from healthcare organizations. In addition, financial burden is shifting more and more on the shoulders of patients, which means providers must pivot towards these changed expectations and support their need for transparency and need for on-demand, convenient, and quality healthcare. At the same time, trying to keep the cost down. More and more healthcare organizations are rolling out virtual care services now. And this trend is accelerating to a point where there is a need to get a handle on managing virtual care programs as a strategic business imperative. Next slide, please. Although virtual care programs have been rolled out by most of the organizations, they are, however, challenged in scaling them out and making them financially sustainable. A couple of months ago at HIMSS this year in Orlando, we conducted a workshop around barriers in adoption of telehealth in healthcare organizations. We had about 15 C-level executives participate from various organizations in the workshop and brainstorm their friction points or major hurdles they have experienced in fully adopting virtual care. We discussed various aspects of telehealth programs and things that need to be stood up for supporting different virtual care use cases. Further, we had them prioritize those friction points. What you see here on the slide is a summary of that discussion. The number one issue that surfaced unanimously was regulatory and reimbursement hurdles. There is a lot of confusion and real struggle to keep up with ever-changing federal and state regulations. Matching current level of reimbursement to the services being delivered virtually is critical to ensure financial success. Another big challenge that was identified was lack of mature telehealth strategy and governance model. Lack of strong alignment between telehealth programs and business objectives creates a lot of friction within the health systems. Establishing proper workflows, ensuring flexible, secure, and nimble IT platforms, in addition to having strong executive champions, are critical for success of these programs. Next slide, please. Before we dive into the next part of this presentation focused on reimbursement, one last thing I wanted to share with everyone. Last year, we had conducted a study with various healthcare organizations around maturity of their telehealth programs. I've listed some key takeaways here. Important thing to underline here was that telehealth should be a proactive program and not reactive, meaning don't design with just one use case in mind, but be deliberate in thinking about how to incorporate virtual care as part of your normal clinical operations. Ensuring smooth experience, both for patients and providers, while delivering virtual care is important for its adoption and therefore financial success. It is critical to ensure organizational and change transformation is understood and managed well. Don't measure success with just financial ROI. We need to account for non-financial benefits that organizations can reap and improve along with. With that thought, I'll turn over to Ayla for further discussion and deep dive into reimbursement policies.
Thank you so much, Atul. And to kick off into this next part of the webinar, Jordana, I would love to turn the floor over to you. And I would like to pose a question. To begin with, there are a lot of moving pieces with telehealth policy, but for those that are less familiar with telehealth reimbursement, can you just set the stage for us from a high level and give us an overview of the policy landscape and telehealth reimbursement with Medicare, Medicaid, managed care, and commercial insurance?
Absolutely. Thank you, Ayla. If we could have the next slide, please. Yes, let's start with how telehealth reimbursement has worked historically and how reimbursement works today. And so from a high level, the rules for reimbursement for telehealth services vary among the different payers. At the federal level, the rules for reimbursement for telehealth services delivered in fee-for-service Medicare are all defined under Section 1834M of the Social Security Act, which was enacted about 20 years ago. And the law allows separate payment for telehealth services that includes office visits, consultations, and office psychiatry services when certain conditions are met. First, the Medicare patient must be located in an originating site in a rural geographic area. This means the site must be in either a rural healthcare professional shortage area or a county outside of a metropolitan statistical area. Second, the law limits the types of settings or originating sites where the Medicare patient must be located when receiving care, And these are to 8 types of medical facilities, such as hospitals and providers' offices. It also specifies which types of healthcare practitioners are eligible to provide services, and it generally requires the services to be delivered using real-time interactive video. Lastly, when all of these conditions are met, then Medicare will reimburse for certain services that are found on the approved Medicare telehealth services list. And the list gets updated annually through the physician fee schedule notice and the comment rulemaking process. And in 2018, CMS added 7 new services to the list. And then in 2019, there were 2 more services added, and we're now at a total of 98 services and payment codes on the list. Originating sites can also be reimbursed for an originating site facility fee. And there are a few exceptions to these rules that I'll talk about in just a few minutes. And then at the state level, the picture is a bit brighter because each state has the ability to set its own rules for how telehealth is treated. And over the last few years, we've been seeing state Medicaid programs being more progressive and trending towards offering more reimbursement opportunities for telehealth and eliminating unnecessary restrictions that are making their policies more telehealth friendly. And then on the commercial side, we're also seeing payers trending toward offering broader coverage of telehealth services, although how much and which services they pay for can vary widely by state. States also create their own reimbursement rules for the commercial payers, which often involve parity in coverage of services, though not necessarily in reimbursement. Next slide, please. So this is how reimbursement has worked. It's been constrained now for about 2 decades, but let's fast forward to the 2017-2018 115th Congress. And during this time, we saw lawmakers introduce bill after bill, trying to chip away at the constraints that have been put in place using telehealth by this Section 1834M. In fact, in the 115th Congress, there was more legislative activity than ever before, and we saw a 48% increase in the total number of bills that were in play that included telehealth provisions compared to the previous 114th Congress. And at the state level in 2018, we also saw significant progress as 65 telehealth bills were passed across 30 states and DC, which represented a slight uptick from 2017. And the enacted legislation focused mainly on expanding Medicaid coverage, establishing regulatory requirements, and enacting interstate licensure compacts. And in 2018, 38 states finalized 49 telehealth-related regulations, which were also focused on practice standards by the professional boards. And then by the end of 2018, every state had established some coverage and reimbursement for telehealth under Medicaid, and the vast majority of states had a private payer telehealth parity law in place, which brings the payers to the table to help support virtual care for their enrollees. And throughout 2018, federal regulators also showed tremendous interest and support for telehealth. For example, we heard from both HHS Secretary Azar and CMS Administrator Verma on numerous occasions that telehealth is a high priority, and not just for fee-for-service, but also with respect to the key role that telehealth can play in value-based care delivery models. Next slide, please. The momentum continued to build on Capitol Hill, and by the end of 2018, 4 major pieces of legislation were signed into law, which included significant policy changes and improvements around payment for telehealth services. The first piece of groundbreaking legislation was the Bipartisan Budget Act of 2018, and this legislation has 4 provisions related to telehealth, with 2 in fee-for-service and 2 in value-based care. The first provision addresses telestroke services, and it removes that rural geographic requirement. So this no longer applies, which allows providers to bill for telestroke consultative services provided to patients in any geographic location. The law also added the ability for mobile stroke units to serve as eligible originating sites. Similarly, for patients with end-stage renal disease who are receiving home dialysis therapy, the rural limitation is lifted, which allows providers to bill and get reimbursed for clinical assessments by telehealth, regardless of geography, and even into the patient's home. Both dialysis centers and patients' homes were also added as eligible originating sites. And these two provisions went into effect on January 1st of this year. Also included in the Bipartisan Budget Act were significant policy changes for use of telehealth in Medicare Advantage plans and accountable care organizations. For MA plans, to date, these plans are only required to cover and pay for telehealth benefits that are comparable to the benefits in original fee-for-service Medicare. And these are the benefits that are narrowly defined by Section 1834M. And so when a plan wants to offer additional telehealth benefits that go above the basic level, such as allowing Medicare enrollees to receive services in urban areas or in the patient's home, they have to do this through a supplemental plan, which gets financed through premiums or through rebates. The BBA changes this by allowing plans to have the flexibility to build these additional telehealth benefits into their basic or core plans, rather than requiring them to do these as supplemental benefits. And then for the ACOs, the ability to use telehealth today is also limited. And under the BBA, this expands the flexibility for two-sided ACOs to provide services to enrollees in urban areas and into the home. And these two provisions go into effect this January of 2020. And as evidenced by the legislation and associated regulatory actions, we're seeing both Congress and CMS pushing the industry towards using more telehealth in these capitated and value-based payment models, because they've come to recognize the value of telehealth and how it can help improve care in a more convenient and cost-effective manner. I also want to mention the Support for Patients and Communities Act, which was another major piece of legislation that was signed into law last October. This legislation expands the use of telehealth for treatment of substance use disorders, and it does this by also removing that rural geographic requirement and adding the home as an eligible originating site, which again opens up payment for these types of services in any geographic area across the nation. This provision goes into effect on July 1st of 2019. The Support Act also contained one other major telehealth provision, which essentially puts a one-year deadline, which is October 24th of 2019. It puts this deadline on the DEA to finally get the special registration set up for telemedicine providers. And this is also very important because it will make it a lot easier to prescribe controlled substances without being required to have an initial in-person visit with the patient. The VETS Act was another bill that was passed and went into effect last June. This legislation implemented the VA's national Anywhere to Anywhere telehealth program. And then lastly, the Agriculture Improvement Act of 2018, or the Farm Bill for short, included a significant increase in funding for telehealth grants, of which 20% will be set aside for programs that address opioid abuse in rural communities. And the bill also included broadband expansion. Next slide, please. On the regulatory front, new CMS payment policies that went into effect January 1st of this year also represent a major shift in attitude by CMS towards telehealth. One of the most significant policy changes was around CMS's decision to introduce payment for new types of virtual care and remote monitoring services that are distinct from telehealth and therefore are not subject to the rural and other restrictions placed on traditional Medicare telehealth services as outlined in the statute. Next slide, please. So let's briefly talk about these pivotal new payment policies. The first category is called a brief communication technology-based service. This is a brief 5 to 10 minute virtual check-in with an established patient to evaluate whether an in-person visit is needed or if an office visit can be avoided. It's a real-time synchronous interaction that can be done by telephone or video. There are associated requirements that need to be met in order to bill separately for these services, but generally virtual check-ins are reimbursable by physicians or other qualified healthcare professionals who are eligible to bill for evaluation and management, or E&M services. And there are no limitations to frequency, specialty, or use case, or setting where the patient must be located. The second new category is called a remote evaluation of recorded video and/or images. This is a store and forward visit. It also must be initiated by an established patient who sends in an image or a video clip to be evaluated by the doctor. And again, just like the virtual check-in, CMS does not limit the use of this code to any specific application or specialty area, so it can also be used very broadly, like for when a patient might send their doctor an image of a wound or a video clip of a neurological problem. In terms of modality, CMS allows the follow-up communication with the patient to take place using the phone, through video, secure text messaging, and other modalities, as long as the communication is compliant with HIPAA. And then the third new category establishes payment for interprofessional or provider-to-provider consultations. And these are without the patient needing to be present. These consults can be conducted in real time using the telephone or video, or asynchronously through the internet or the EHR. CMS finalized 6 of these codes for billing by both the requesting and the consulting practitioners, all very exciting. Next slide, please. Finally, there were also really big payment changes for remote patient monitoring. And for RPM, CMS finalized 3 new payment codes, which augment CPT code 99091 that was unbundled for separate payment in 2018. These new codes enable separate payment for the full range of professional services and technical activities, or the practice expenses associated with remote patient monitoring that include educating the patient, setting up the equipment in the home. The rules also allow remote patient monitoring professional services to be billed with chronic care management service codes in the same month for the same patient. So Ayla, I hope this gives everyone a sense of how reimbursement for telehealth has worked, how it's been evolving very rapidly now, and how the payment rules generally work today. Back to you.
Thank you so much for that high-level overview. And now I'd like to just dive a little bit deeper. So as you mentioned, the 2 significant policy wins for telehealth were the passage of the Bipartisan Budget Act of 2018 and the Support Act. What do you think the impact will be of these policies?
Right. Well, in fee-for-service, for telestroke and end-stage renal disease, it's already making a really big difference on both patients who are receiving these benefits and this care, and providers in terms of finally getting nationwide reimbursement in place, which now allows programs to initiate these services, as well as it allows those who have been delivering these services without getting paid by Medicare to finally be able to bill. And just to get an idea around the impact on telestroke alone, we know that about 80% of all strokes in the US occur in the Medicare population, which is about 640,000 people every year. And of these people, about 90% of them show up in non-rural emergency departments, where prior to January of this year, there was virtually no payment for telestroke services because of the rural limitation. So with passage of the BBA, now providers can bill and get paid for these services provided to every stroke patient in any hospital across the nation. And then beginning on July 1st, when the Support Act kicks in, there will be nationwide payment for providers who can help bring treatments and support to those who are suffering with substance use disorders. This is huge. And then for MA, for Medicare Advantage, today there are about 20 million Medicare beneficiaries who are enrolled in these private MA plans. And as I mentioned, these plans are only required to pay for telehealth benefits that are covered under an original Medicare plan that's defined by 1834M. Well, the BBA changes all of this, and it gives MA plans tremendous flexibility now to offer a broader range of telehealth benefits that are not otherwise available to Medicare beneficiaries. And these changes will certainly benefit both plans and enrollees by enabling the plans to finance the cost of these benefits, through the government paid capitation without relying on rebate dollars or additional premium charges. And then for accountable care organizations, the ability to use and get paid for telehealth services today is also limited, except to a few types of ACOs, like the next-gen ACO. And so this law will allow other types of performance-based ACOs to have the same level of flexibility to use telehealth for their patient populations. So these pieces of legislation that increase flexibility around the use of telehealth and remove the arbitrary rural and setting requirements, which allows reimbursement on a national scale, can have a tremendous impact on adoption and utilization of telehealth, which ultimately enables better patient care.
Wow, thank you for outlining the impacts of the BBA and the Support Act. I would really like to kind of continue the discussion and talk a little bit more about the VEST Act as well. And Christian, I'm going to turn the floor over to you for this part. And my question about this is, the VEST Act was another key bill that was passed that allows VA providers to deliver care to patients across state lines without the need to get a license in every state. And Christian, do you see similar licensure policy changes being enabled for private sector providers?
That's a good question. So Jordana had mentioned it briefly before, but this is a huge leap for telemedicine and telehealth advocates, especially from a congressional support level. However, we still have these barrier to entry challenges. They still exist. Number one, of course, being reimbursement, but a close second is licensure and adoption. Outside this federal arena, it really goes down to a state-based matter. We do have licensure compacts that are being implemented, like the Nurse Licensure Compact, or NLC, and the Interstate Medical Licensure Compact, the IMLC, which actually 80% of practicing physicians already meet licensing criteria for. These are all very helpful, but the underlying problems still exist. We need more representation. We need more states to join. Additionally, we need process improvements. It really boils down to a national telehealth program versus state issues.
Thank you so much, Christian. And I think that Jordana, I'd like to turn the floor back over to you now and to kind of talk about what's happened since the passage of these bills. So, what telehealth policy related initiatives are happening in 2019 at the federal level or under the 116th Congress, and what's happening at the state level across the nation?
There is a lot happening, I can tell you that. In the 116th Congress, wow, since January 1st of this year, there have already been 25 bipartisan bills that include telehealth provisions that have been introduced. And this number already exceeds the number of bills introduced by this time last year. And these bills that have been introduced continue to focus on removing restrictions placed on telehealth and expanding access to care. Just to give you an idea of some of these bills, there's the Mental Health Telemedicine Expansion Act, the Comprehensive Addiction Resources Emergency Act, and the Youth Mental Health Services Act, all of which aim to increase access to needed mental health services through the use of telehealth. And there's also a focus on chronic disease management for congestive heart failure and chronic obstructive pulmonary disease. We're seeing these coming through in the Fair Care Act and the Better Respiration Through Expanding Access to Telehealth Act. And these bills would expand access to respiratory therapy, audiology, and outpatient therapy for PTs, OTs, and SLPs through telehealth. There's also interest in maternal fetal medicine. There was the MOMS Act and the Mommies Act that were both introduced in the last Congress. And the Mommies Act has recently been reintroduced by the Senate. And the Mommies Act targets policies to improve maternal and infant mortality rates here in the US. In terms of what's on the horizon, I mentioned the RUSH Act that will likely also get reintroduced very soon. This bill focuses on providing acute care on site and through telehealth at skilled nursing facilities to try to prevent unnecessary hospitalizations and emergency department visits. And then also there's the Connect for Health Act, which you may recall is a very large comprehensive telehealth bill. It has a menu of telehealth provisions, and some of these provisions were passed in the Bipartisan Budget Act. This bill is anticipated to be updated and reintroduced as well, perhaps pulling in suggested policies from public responses to an RFI that was issued recently by the Congressional Telehealth Caucus Committee. And then at the state level, the momentum is also building around removing restrictions to increase access to care. And in particular, states are focusing on legislation around parity laws, joining interstate licensure compacts that Christian just mentioned. They're working on expanding coverage and reimbursement, especially for telebehavioral health services and mental health services. They're also looking at expanding settings into the home and schools, and also around expanding the list of eligible providers. Back to you.
So it looks like there are a lot of changes on the horizon at the federal and state level. And Christian, I'd love to follow up with you with another question about, what other activities do you anticipate happening on the regulatory front that will impact telehealth this year?
Well, we really need to break this down into two parts. We need to look at this from a federal level perspective and from a state level perspective. At a federal level, payment policies we already see are likely going to be expanded. We're anticipating 2020, the physician fee schedule and proposed rules that are coming out in early July are going to have a lot of proactive changes from CMS as we saw before in the 2019 schedule. So we're really expecting great things to come out of those changes. Additionally, from a CMS and CMMI, which is the Medicare and Medicaid innovation side, there's already been pilots that will be announced that have gained momentum and regulatory sprints that are already underway to improve interoperability, privacy, Stark laws, anti-kickback laws, and then looking at a state level. How do we make this work? Well, we look at expanding our practice guidelines and what our limitations are and where we can go. Really, the only way to do that is by removing those barriers from a state to state. We continue to see these positive healthcare trends, and we hope to see more. Back to you.
Yes, thank you. And with all the momentum around telehealth policy, Jordana, how do you think healthcare systems, payers, and others should be thinking about telehealth and these new reimbursement opportunities?
Well, I think we've reached a turning point or an inflection point in terms of attitude, where policy and telehealth technologies are coming together in very significant ways. There is new payment now for virtual care services that includes the brief virtual check-in. We now have store and forward visits and provider-to-provider consultations that are not subject to the telehealth restrictions under Medicare law. There's payment now for telestroke and end-stage renal disease in any geography. And for remote patient monitoring, the economics and business model for this case have also changed considerably. So all of these new payment opportunities could be an entry point for starting a telehealth program or a new revenue stream for programs already delivering telehealth services for free. So if a healthcare provider isn't currently billing for these services, this is the time to get set up and to do this. And then for private insurers with Medicare Advantage products, there are new flexible rules for the use of telehealth that can help deliver more cost-effective, convenient care to enrollees. So as you can see, there is a lot happening, which is very encouraging. It's very exciting. And I think we will continue to see these positive advancements, both at the federal and the state levels, as leaders continue to build on the momentum to break down the restrictions and enable broad reimbursement for telehealth services in fee-for-service, as well as moving us forward towards value-based cares. So I think it's important for providers and payers to be proactive at this time, get familiar with the policy and reimbursement opportunities and changes, and this way they'll be able to take advantage of them.
And thank you, Jordana. And what can others do to help accelerate remedies to policy barriers that are hindering telehealth adoption?
Great question. Well, I think, as I mentioned, it's a really, really exciting time, and the tide is certainly turning in our favor, but it's also important to recognize there is still a lot of policy work that needs to be done. And so advocacy is key to advancing remedies to the policy challenges that we still face and need to help to drive adoption of telehealth. So advocacy is something that we can each take part in. And many of you may already be involved in advocacy, but if you're new to this, I would certainly encourage you to reach out to your legislators, your senators, your representatives, and your regulators, or the sponsors of the telehealth bills and other leaders on the Hill. Meet with them, talk with them about telehealth, share your experiences and your challenges. And I must say, they really appreciate hearing from constituents, and they really love learning a lot from everyone. So this is also the time for health systems and providers to talk with their plans about telehealth and the new Medicare Advantage opportunity, as well as to encourage them to adopt more telehealth in non-Medicare Advantage plans. At InTouch Health, we are actively engaged in advocacy and outreach on Capitol Hill, and also with the Department of Health and Human Services, HHS. And we see tremendous value as well, working together with others in the industry in order to be a more coordinated and powerful voice for change. So if any participants on the webinar today or share this interest, please reach out. We'd love to hear from you.
Great, thank you, Jordana. And Christian, I would like to follow up with you. Could you kind of explain what online resources are available for those who have an interest in learning more about and keeping up to date on the telehealth policies and reimbursement?
Absolutely. First, understanding, there is material out there that you can follow and get educated on. There's a lot of good websites like the Centers for Connected Health Policy. This is a nonprofit group, a nonpartisan organization that works to maximize telehealth's ability to improve outcomes, care of delivery, and cost effectiveness. Also, there's the ATA, the American Telehealth Association, another group that's committed to ensuring that patients have access to safe, affordable, and effective care when and where it's needed. And of course, understanding legislative policy, you can always go to cms.gov for the Centers for Medicare and Medicaid Services, and also congress.gov, which is an excellent resource for looking at your current legislative activities and what's going on around you. Back to you.
Great, thank you for those helpful resources, Christian. And Jordana, can you tell us about the educational programs that you offer on telehealth reimbursement?
You bet. So education is also a big part of what we do at InTouch Health. And because reimbursement is challenging, it is tough to stay on top of it. There's so much happening. It's certainly top of mind for many of us in the industry. And so we periodically offer educational webinars on telehealth policy and payment themes. But I did want to mention that we have a 4.5-hour workshop called Telehealth Reimbursement, The Essentials of Getting Paid, that we're offering coming up on July 15th, which will be just prior to our annual Innovation Forum, which is a 2-day educational event on July 16th and 17th in Santa Barbara. And I'll join an esteemed faculty of telehealth experts, and we'll take participants on a deep dive into how fee-for-service telehealth reimbursement works for all the payers for different areas of clinical practice. And we'll cover in depth the key legal and regulatory and compliance topics all related to payment. We'll dive into how to approach private payers to discuss getting paid. And we'll talk about tips and best practices for documentation and submitting claims. So we would encourage anyone who has an interest in this, in joining us, to go up to our website at In Touch Health and to learn more. We hope you can join us there.
Great, thank you so much, Jordana. And before we wrap up, Christian, did you have any additional information you would like to work through today?
I think if we go to the next slide, we'll kind of go through the way that we're transitioning the future of reimbursement. We all know that we're going to value-based care, and that's well underway. But there are different models that are being offered that help with the increased flexibility for those value-based care organizations to use telehealth. Transitioning to capitated pay models. You know, we talked about bundled payments, accredited care organizations, and Medicare Advantage plans. But now telehealth is going to play a larger role in these value-based models. We're hoping to see it drive better, more efficient, and cost-effective care. And actually, to the provider's bottom line, there's going to be a direct impact when using telehealth services. Next slide. So as we discussed, CMS continues to drive our value-based care transformation. They're doing that through bundled payments, such as comprehensive care for joint replacement, payments for care improvement, Medicare Advantage plans, and ACO pathways to success programs. The Centers for Medicaid Models for Innovation includes next generation ACOs, value-based insurance design, and emergency triage, treat, and transport. But what does that all mean for the changing dynamics of healthcare, and how can an organization be ready for these changes? Next slide. So we know that healthcare is evolving. We know that there's changes coming every day, whether that's consumer expectations, having a greater financial responsibility, and better experiences. We're looking at the reimbursement shift of improving our overall outcomes, decreasing our costs, and increasing access to healthcare. We're aligning physicians. Reforming and reimbursement shifts are driving hospital and physician alignment. You know, we talked about the new regulatory demands and the complex regulations for quality and the overall care of delivery. And last but not least, you know, we're still fighting with narrow margins. Hospitals operate on a 1% to 2% profit margin. The pressure to control spending, reduce utilization, those are going to drive those margins down even further. So working with NTT, we offer solutions and services to assist with those in a consulting and solution capacity. We look at your overall infrastructure assessment, doing specific workflow optimization and telehealth best practices. What can we recommend to your organization that fits your needs best? Looking at security and setup for access controls, installation and maintenance of IT, supporting new policies and procedures, and then driving that home with the end users. Who's actually going to be using the services and the software? And at the very end, how are we supporting each other through the telehealth implementation? And can we monitor those results on the back end? Next slide. So this is all brought together by looking at insights, solutions, and outcomes. And looking at your comprehensive, efficient implementations to optimize telehealth workflows, NTT can really help you reduce the risk, optimize cumbersome workflows, simplify the convolution of federal and state mandates, and enhance your overall infrastructure. That can be done by joint partnerships and relationships. We want to ensure your organization achieves the full power of the telehealth platform. Utilizing those relationships, we have former CIOs, we have experienced clinicians, security and privacy specialists, as well as for visuals that they have expertise in infrastructure and optimization, looking at interoperability and technology. At NTT Data Services, we do have expertise and proven methodologies, and because of that, being a leader in the healthcare space, it's our goal to deliver targeted, segmented solutions and commitment to deliver outstanding work for your facility, with the overall goal being to provide your organization long-term partnerships and a commitment to helping you achieve a higher quality of care with telehealth. I'm going to go ahead and pass it back to you, Ayla.
Thank you so much, Christian. And thank you, Jordana Atul, as well, for the fantastic presentation. We are now going to begin today's question and answer session. So please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. And we'll try to get through as many questions as we have time for today. We've already had several questions come in, so I'm going to go ahead and just start with those now. So this question is, for someone who is just starting out new, which use cases or conditions should we treat with telehealth to begin with?
Shall I jump in?
Yeah, Jordana, if you want to address that, that would be great.
Sure, I can give it a shot, and maybe Atul, feel free to jump in, Christian. So I would say, a health system should think about their patient needs and kind of, what's going to make the most sense for their patient populations, and certainly keeping in mind the new reimbursement opportunities. For example, telestroke now has national payment, and we've got lots of service payment codes for stroke, for telebehavioral health and such, that could really help make the difference there. So I would say look at patient population and kind of what your needs are, and go from there.
Jordana, thank you. This is Atul here. Just what you said, I agree with that very well. The only other thing I would add is for the acute care settings, telestroke, tele-ICU, and like you rightly said, the mental health consultations, doing all these consultations via virtual care would be very beneficial and easy thing to address. But if you are a practice or a primary care practice or some large group over there and trying to increase your revenues and at the same time provide extended services to your patient population, think about urgent care services or off-hours services that you can offer using virtual care. By offering those services, automatically gives your existing patients an additional avenue to contact you, and make sure that the continuity of the services is maintained, but also drives a lot of new revenues that otherwise you would be lost to you, right? So those things are very low-hanging fruit. We see a lot of practices embark on those journeys. Very easy use cases.
Great. Thank you both, Jordana and Atul, for your responses to that question. I think it was very helpful. And we've had several other questions come in on a variety of topics. So this next question, Christian, feel free to weigh in on it, or Jordana. This person wants to know, do you ever see CMS easing the restriction on the originating site to include the patient's home?
Well, I'll jump in on that. CMS does allow, I should say, the home as an originating site for the new virtual care codes. So, so for the brief check-in, the store and forward visit, the beneficiary can be in the home environment. As far as the other Medicare telehealth services on the list that's subject to the 1834M restrictions, those are set by the statute. So adding the home as an eligible originating site would have to happen through legislative and congressional action. That would be the only way to make a change to get the home added as an eligible originating site for those services.
And just kind of to expand on that too, we talked about the VETS Act that is looking to gain speed and momentum to provide care to veterans. It really boils down to a federal versus state issue, and if we can get that support at that level, I can see that happening as an originating site, with Congress being the backer of that, kind of supporting what Jordana said.
Thank you both. We've had a few more questions come in, and this next question is for Jordana. And the question is, what do you recommend for a telehealth program set up for commercial payers? Is retail cash setup ideal, or should we just expect no payment for these services?
I'm not sure I understand the question. Can you read that again?
Yeah, so I think the main part of the question is, what do you recommend for telehealth programs set up for commercial payers? So,
right. Yeah. Mm-hmm. Well, I think that, what I would recommend is that you go and talk to the payers that you're working with and talk about the services that you're providing, and how telehealth can really help deliver more efficient, cost-effective care to their populations. And certainly private payers are already covering some telehealth benefits and paying for some services. And so I think, having that conversation with them can really help go a long way.
Great, thank you so much for that, Jordana. And I think that we've had a few more questions come in. I know throughout the presentation you provided a lot of great educational resources and talked about training programs, but this person just had a question. Is Medicare offering any new training on these codes for hospital billers and coders? So if Jordana, Christian, Atul, if you have any insight, if there's any training available, we'd love to hear about that.
Well, I'll jump in. I know that CMS offers webinars here and there. In fact, there's one coming up on diabetes programming. They also have fact sheets and newsletters. So I would encourage anyone to go to the www.cms.gov website, and you can sign up for alerts, and they'll let you know when webinars are happening. I'm also aware that CMS will be releasing some additional guidance. I know we're all sort of waiting for it, and they've been saying that it will be coming. So I think we can look forward to getting some more specific information, especially around the new codes that came out that went into effect for January 1st of this year.
Great, thank you so much. It looks like we have time for maybe one more question. And this person is asking about if a provider is in one state, can they provide telehealth services to a patient in a different state? And Jordana, I'm not sure if there's an easy answer for that, but would love to hear your insight on that.
Sure, well, absolutely. I mean, what needs to happen though is the provider needs to be licensed, to get the license in the state where the patient is located. And so that's really the main thing there. And then, you want to look to see if states are parts of licensure compacts and things like that. But the general rule of thumb is that the provider needs to be licensed in the state where the patient is located.
Great, thank you so much. I think that's all the time that we have to work through questions today, but I really want to once again thank Jordana and Atul and Christian for their excellent presentation, and to NTT Data for sponsoring today's webinar. We really appreciate you all joining us. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.